afternoon. I hope you had a good afternoon tea. I was just trying to demonstrate what happens if you don't have good teamwork and briefing. The result in this circumstance is that your slides don't come up when you thought they would, because I didn't talk to the team down the back and I didn't check that they had the slides and I didn't tell them I was going to come up and we were starting a bit early, all of which resulted in me waiting up here, you waiting down there, and then it's starting on slide 5. So, you know, a classic example. If you don't do it right, you don't get the outcome that you expect. So what are we talking about? I think you all know what we're talking about, and you've had a chance to consider this as well and have been talking about it in the table work up until now. A briefing is a way of sharing vital information, potential and actual safety issues, and they're encouraged in a team environment where you can share information without concern about asking silly questions. Debriefings is at the end of the list and usually include statements about what went well, what needs improvement, and in particular that they happen in an environment where there is a structure in which resolution can take place. That is that there's no point in having a debriefing and identifying things that need to be resolved if in your operating room suite or in your hospital there's not a practical way of resolving them. Does it make a difference? Well, Laurel E. Lingard has written quite a lot about this over the years, analysing the outcomes of bad communication, and in her assessment 25% of operating room communications fail. And what do we mean by fail? One of the features, of course, of good communication is closed-loop communication, particularly in an operating room environment. An operating room communication that fails might be if I was doing a FemPop bypass and decided that I needed a completion angiogram, and as I was getting towards the end of the case, I said, "Oh, can somebody call the radiographer?" And just made that comment and carried on. And then 10 or 15 minutes later, turning around and saying, "Was the radiographer here yet?" And everyone looks around and realises that nobody had actually called them because we didn't have a closed-loop communication. A closed-loop communication might be me talking to the circulating nurse and saying, "Mary, would you call the radiographer now?" And Mary's saying, "Yep, that's fine, I'll call the radiographer now." And I'm saying then, great, knowing that the loop has been completely closed and that I've had a statement, somebody's confirmed that their interpretation of what I've said is the same as mine, and it's come back to me. So the effects of that, and of course I wouldn't get terribly grumpy about it, but there are effects which might include tension in the team, inefficiency, because now I've wasted 10 minutes, because if the radiographer's there, we'd be able to have the angio straight away. Now we've got to wait 10 minutes until it comes, which is a waste of resource, a delay, and ultimately procedural error. So I gave an operating room an intraoperative example, but the same comments could be made about briefings as a whole, and if I remember, I'll make a couple of similar comments in relation to briefings. So how do we solve this in other team games where we want a combined outcome? How do we solve it in the military? How do we solve it on the rugby field or in any other team sport game? We have a briefing, we have a game plan, and then everyone knows what the overall objectives are, so that if things don't go exactly as everyone's anticipated, they nonetheless know where we're trying to get to and are able to use their own skill and resources to try and get to the team goal where we're all trying to get. So, you know, there's not too much different in this sort of activity as there is in surgery. We're after a team goal, a successful operating list with safe surgery for a group of patients. We all have individual goals. I want a good day. I want to feel valued at my work. I want to finish on time. But the overall team goal is that safe, successful, quality surgery is performed on the patients who are on the list, and it is done in an effective way. So the military have briefings, sports people have briefings, and if we want teamwork and communication to be good, we've got to have a number of features that are part of our process. And we often talk a lot about team leadership. You know, I've probably heard it said here a couple of times today that one of the reasons that the HUT systems worked well is that there was good team leadership, and that's absolutely a component of good teamwork and communication. But there are some other components as well. These two I always get mixed up, but they're sort of similar in a way. Mutual performance monitoring and backup behaviour. This is the sort of activity where somebody is aware of how people are performing, and if they need additional resources, if they need additional backup, if they need some sort of extra resource, then that's provided. Somebody's keeping an eye on that process. Adaptability, I don't think we do too badly in this area. I mean, in the operating room, it's always a changing environment. There's always something different. The operation changes, you've got more patients on the list, somebody drops out, all of those things. I think we have a reasonable degree of flexibility. And I've just mentioned about the team orientation, which has to be there. What is the team goal, not our own personal goals? And if all of those things are working, we have three overarching components. I won't mention closed-loop communication because that's I've already talked about that. But the two others, and this I think is the most important one, the shared mental model. Everyone knowing what it is that we're trying to accomplish and making sure that we are in the same space. So anticipating and predicting each other's needs and identifying changes in the team task and adjusting strategies as needed. So, we need to have appropriate knowledge of what's going to happen. Now, obviously, a classic example of a shared mental model not existing between the moat builders. Yes, they're building a moat, and yes, that's a circular thing and it goes round, but they didn't have quite the same vision as the king had about where things were going to go. And the other thing is obviously mutual trust. It's hard to have mutual trust. You're all my team today. I don't distrust you as people, but I have no idea whether you are able to be a really good scrub nurse for a neurosurgical case, or whether you know the instruments for a vascular case, or whether you can manage the staff because you have the seniority to know. But when you have a briefing and you know exactly where what people's attributes and skills and background are, then you have mutual trust. I know that you have the background to be able to undertake this task, and therefore I can safely trust you to do it. So here's an example of a paper, again by Laurelie Lingard, demonstrating the effective briefings may have on the performance of an operating room environment. And this was a structured briefing that was introduced into, it's a before and after study, but it was introduced into an operating room environment. And what they found was that about a third of the communications actually had some sort of real change in what was going on, and about half of the events had a direct impact on patient care. So the actual information that was conveyed in a briefing made a difference in terms of the patient outcomes. And if we look at this in graphical form, here before is these light bars. So before they introduced briefings, there were sort of not uncommon to be at least 3 or 4 communication failures. And we know from the previous effect that half of those would have an effect on what happened to the patient, and a third of those would have some practical. And so 1 to 2 of those would actually make a difference to what happened to the patient. And that was, this was happening on a regular basis, whereas after they had the briefings, it was much more common that there would be no or 1 communication failure. In the pre-intervention, before they did the briefings, 340 communication failures, about nearly half of those had some visible consequence in terms of patient care. After it, not 0 by any means, but look at that, only about a third of the number of failed communications with a visible consequence. So communication's a really important part of having a good outcome. So what are the barriers to effective briefings? You might say, we've said, Liz has talked about some of the barriers, and you've talked about it, I know, already. And I've just put up some words there. I'm not going to elaborate on those, but those are just sort of starters for 10 to get you thinking about what the barriers you have either seen in your environment or what you imagine the barriers would be. If I said to you today, I want you to go back and run briefings in your operating room next week, starting on Monday, with whatever team, you would think, oh my God, no, that's not going to happen. So why is it not going to happen? What would be the barriers? And then how would you resolve those? So those are potentially some of the barriers. And we're going to have a little table work after this, and I'm going to ask you to try and help me identify what the barriers are. I think I know a few of them. People have told me a few of them, and I've experienced a few of them, but I'd be interested in your feedback as to what you see the barriers and what the potential outcomes may be. And I put this up just to go back on the military agenda, just simply because this was on TV about about a month ago, one of those Gallipoli programs, the Australian one, and it was about the battle at the neck, where the Australians were going to advance over some pretty inhospitable ground. It was a very complex plan. The New Zealanders, we were meant to have taken Chunuk Bair at this stage and come down from one, and the English were meant to land 35,000 light horse in some beach, and it was all meant to come together, and it was a very complex plan. And the general presented this plan to all his unit commanders, and they looked very worried, and they said, "Oh, look, this is a really complex plan, and you haven't given us much time. We better get out of here and brief the men straight away so that we can get this sorted out." And he said, no, don't want any briefing. It'll be too kind. They won't understand. Just go and do it. And the end result was, of course, the British didn't land because they thought it was a bit dangerous and didn't want to do that. The New Zealanders didn't quite take Chunuk Bair in the time that was involved, say, with the late. Nobody really understood how long the barrage was meant to last from the naval ships, and it stopped early, giving the Turks about 10 minutes to get ready for the inevitable. And then the Australians advanced. We don't actually, I was not nearly as familiar with this from the New Zealand perspective, but they got completely slaughtered, and it was a complete botch-up, and an example in the military sense of why, it's almost inconceivable at a military level that you would conduct an operation without a briefing. Doesn't mean there's not leadership, doesn't mean there's not good communication, does not mean there's a chain of command. All of those things are actually in place. But the idea of, I'm going to come along and do an operating list today, I know what's on the list, you guys have got some names, you have no idea. You have no idea what I'm going to do. I might do something like I regularly do, I might do something completely indifferent. One might be listed as X operation, which takes 45 minutes, but I know it's going to take an hour and a half. I might not know what the anaesthetic is, but the anaesthetist, he's one on your table, maybe he or she knows what the anaesthetic is. All I know is the patient's got to be sort of anaesthetised somehow. The idea that you'd actually take that approach and expect a successful outcome is really, it is truly unbelievable that we would take that approach. Yes, I know we do communicate a little bit anyway. It's not as if we're necessarily totally covert, but we do not, as a routine, have a team briefing before we start an operating list. And that's what we've got to try and introduce, because that will result in more surgery, a better team, and also, just incidentally, an environment which is safer for the patient. Now, I've sort of put these two things, and this is why I think this is an easier sell in some respects than the checklist. The checklist we've put in, sign in, time out, sign out, because we know it will make it safer for the patients. Doesn't make my life any easier as a surgeon, doesn't make your life any easier, but we do it. We've mandated it, we feel forced to do it because we don't want to operate on the wrong leg, we don't want to operate on the wrong patient, we don't want to leave swabs inside, we don't want to miss out giving the antibiotics and have a chance that the patients will get a wound infection, etc., etc. So we do it, but it doesn't make my life any easier or your life any easier. On the other hand, briefing, and to some extent debriefing, they might make my life a whole lot easier. So that when I'm doing the case, because I've described maybe I'm going to do a carotid endarterectomy, and occasionally when I do a carotid endarterectomy, you as the team know that I use the iron intern retractor. So in the briefing, you ask, as we're presenting that case, say, do you want to use the iron intern today? And I said, yeah, I think probably I do. So that when I'm halfway through that case and I've realised I need a bit of more retraction up here, and I ask, can I have the iron intern? Instead of the, yeah, okay, we'll just go and get it and waste 10 or 15 minutes, it's right there. When I know the patient's already on, and I've left them on aspirin and clopidogrel, just stopped their warfarin a little while ago, and I think this will bleed a lot, I better have some thrombin and gel foam and a bit of flow seal as well, and I've mentioned that in the briefing, then it's in the room. You look good because you've got it right there. Can I have some flow seal? Yep, we're just mixing it up now. Fantastic, that's great. And it saves 10 or 15 minutes. So at the end of the day, we add all these 10 or 15 minutes together, then we might actually even get an extra case, or at least we might get the last case in that we put on the list that you would otherwise cancel. So, we get it all done. So what's the result of that? The patient is having their surgery in a safer, generally safer environment. There's no specific things. It's not going to make us operate on the right leg if we were going to do the wrong one. It's not going to save us swabs, but it's going to be an environment where I'm feeling happy because everything's just humming along. You're feeling highly competent, and because you've everything that's happened has been predicted, you've had a chance to ask, And the manager's going to feel happy because we might have even added another case on. We might have, it's a bit like the house of God, isn't it? If you do really well, they give you something hard to do. So we might have even finished early and they would have said, oh, that's great. Can you do an acute, please? It's on the board. So all of those things, the surgical team, the anaesthetic team, the operating room team, and the managers have all got to areas to benefit from beefing and debriefing. It'll make us feel better. It'll make our day better. So we don't want to be like that. What about debriefing? Well, there are some additional and different challenges to running a debriefing. I just put up a few there that occur to me, but again, I'm not going to elaborate on those. I'm just going to ask you to contemplate. If I said, I want on Monday for you to run briefings, and at the end of the operating list, I want you to have a debriefing, I want you to imagine what the challenges would be for that, what the barriers would be. See if you can write those down, and as you're writing down the barrier, X, what the solution might be, or what the potential solution might be for that. And just to digress a little bit, I mean, in terms of some of the work that we're doing, not directly related to briefing, but just the benefits of engagement. This is some of our experience in Auckland with using the paperless checklist, and obviously, as you know, we are moving from a piece of paper held by somebody that's not scrubbed in theatre, or not scrubbed in the operation, ticking the boxes and reading out and then signing the bottom. We're moving from that to encourage you to use a poster on the wall which has got the elements of the checklist on, and getting 3 different groups of people: the anaesthetist for the sign-in, the surgeon for the timeout, and the operating room nursing staff for the sign-out, getting each of those 3 groups to lead those 3 separate parts of the checklist. What we found in Auckland was that 3 different studies, not done for this, but just the data is useful to compare. In sign-in in Auckland, we tend to not have the surgeons present because it's done well outside the operating room. So our goal is 2-team engagement. That is engagement of the nurses and the anaesthetists. And by engagement, I'm talking about all of those good behaviours which are associated with engagement, like paying attention, not doing another task, asking relevant questions, those sorts of things, as opposed to lack of engagement, which means either not doing it at all, or carrying on with another task, having a conversation, talking on the phone, generally ignoring things. And back in 2011, we did a study, and we found that our engagement, our 2-team engagement for sign-in was about 50%. Our 3-team engagement, which involved the surgeons obviously as well, for timeout was about 40%, and we didn't have enough data at this stage for sign-out in that particular time phrase. And when we did it again in 2013, slight fatigue factor, probably, people getting used to it, people not engaging as much, particularly relevant in the timeout, where the engagement had dropped down below 20%. That means if I was watching a team doing a timeout, that only 1 in 5 times could I say that all 3 team groups, the nurses, the surgeons and the anaesthetists, were engaged in the timeout. Since we've gone to the paper-based checklist, you can see that in all 3 areas, the engagement has dramatically increased. And that's partly because the groups that were hardest to engage in a particular part are now in charge of that particular part. And so we've got the anaesthetists involved in running the sign-in, the surgeons are running the timeout. Hard to be not engaged if you're actually running it, and the other groups tend to be involved as well. We still have a problem with sign-out, but it is better, and I think there's some more work to be done there. And what about the non-debriefing? And again, this will suffer probably from some of the issues that are true in sign-out as well. That if we don't recognise what it is that we could fix by the next list, we'll just do the same thing again, and we'll be equally frustrated the next day when the retractor arm is broken and doesn't work, and it still doesn't work, or the PACS machine screen is not working properly and it's still not working. So we've got to change those things. For effective briefing, we also need some form of guide, because as for time out and sign out, in your mind, you might know, I know what I'm going to do. I'm going to introduce everyone. I'm going to describe the list. I'm going to get everyone a chance to say things. I'm going to go through the cases one after another, and then I'm going to wrap up and ask if any final comments. And probably I'll do that, reasonably well most of the time. But having a little guide focuses me, and it also focuses the rest of the team on what we're doing. It's not a surprise then. Everyone knows exactly where we're going. And this is an example of a tool that, like most things, like the World Health Authority, World Health Organization's draft vanilla version of the checklist. It was a good template for us to start. Some people did use it in the vanilla version. Most people adapted it slightly, and so this is something that would fit into the same category. And the checklist starts with, the guideline starts with introductions for the briefings, the list outline, the cases on the list, the time, any changes, any uncertainties. Things go in there like the overall list, like the charge nurse says, there's going to be a fire alarm at 11 o'clock. And we all look, oh my God, we have to stop the list, stop the anesthesia. No, don't worry, she said, don't worry. We don't have to do anything radical and carry on operating, but I just have to go outside with a list of who's in theatre and tell them that, these are the people, and obviously we can't have anyone coming and going. I thought, that's good. So when we hear the alarm go off, we know exactly what's going to happen. Or something might be, we've got some important visit. The chairman of the board wants to come in and see how they're operating. He's going to come in at 2 o'clock in the afternoon. Oh, okay, we better be on best behaviour at that point. Or, all of those things that otherwise might disrupt things are actually known, and everyone's clear about things. Then there's the case. Now this is not like a timeout. This is not checking the patient's consent or any of those sort of things. This is okay. The first case is aortic aneurysm. I'm going to actually do him retroperitoneally. Oh, okay, right. So that means he's got to be on his side, and we talk about that. Also, did you want both the iron intern and the booklet? Yeah, I usually do. That's quite helpful. Thank you for remembering that. That's good. All of those sorts of things about an individual case. The anaesthetist will obviously have their little bit, and the nursing staff may have other specific things about, what's their requirement. And then, having gone through all of the cases on the list, then any other final things, any other nursing concerns, any other anaesthetic concerns, fine, let's go. For the average list, this takes no more than 5 minutes. It could take as little as 3 minutes. It's very seldom takes more than 5 minutes. It's a very quick process, and all need to be present. A guide or checklist, I think, is preferable to use. Open communication, cooperative environment, shared goals. So everyone knows what the game plan is, and at 8:05 in the morning, everyone will know how the day should come out, and everyone's shared the information that they have because of their background to contribute to the whole. And it's likely that introduction, in my view, is much more likely to make people talk up during the operating room environment than the introduction that we do at timeout, because this is a non-threatening opportunity for you to put your skill and knowledge to use and ask relevant questions, which you probably would ask anyway, but this is just in an open environment. What about a debriefing? There's a few challenges with how we run it, and you're going to help me identify those. Need all present, needs to be constructive feedback, areas for improvement must be identified, and the place where issues go for resolution must be clear. And we've heard about how Liz managed that in the hut, and I think the idea of possibly some documentation of issues to be resolved is relevant, because otherwise it goes in the verbal ether and possibly goes nowhere. Well, there's no record that you even had the discussion. So these are the questions I want you to solve. What are the barriers, and have you experienced them, and what solutions can you accept? This is to briefing. And what about debriefing? Have you got a good closed loop system in your hospital, and how do you resolve the logistic challenges? So I'm going to leave you on the table. There's probably those big bits of paper still. Why don't you use one for briefings? Tell me what the barriers are to briefings and how you think I should promote solving them, and what the barriers are to debriefing and how you think I should promote ways of solving them. And if you can do that for 10 minutes, then we'll go around and see what solutions you've come up with. As a plastic surgeon, operating. See, he says I can't find his wallet. I sometimes say that. Remember in the movie Alien? Yeah. The guy who wrote Alien was a patient at UCLA. He had ulcerative colitis. It was a Crohn's. He had one of those, and he just said, because whenever you have a flare, his abdomen hurt so much. And he always thought that it was like an alien, and so that was part of writing that, and that's why in that one part of the movie when his thing explodes out, it was just like his way of saying that this is how bad my disease is.
Certainly very memorable, Sigourney Weaver, absolutely.
Yeah. That's
That's
one
for St. John. That's corporate cabs, and this is one that I have for my own personal life. But it just means it goes on account. You don't have to worry about money all the time.
And the advantage of that over a credit, just using a credit card.
Oh, you don't have to get one back. Because it's the account's held by the commission.
right, I think we're at a point maybe we should hear each other's thoughts and I can take them on board. And please, the A2 pieces of paper that you've written, which I'd like to collect those up at the end so that I can help put that together and add to my list of things that I want to do. So let's hear from this group first about briefings and the barriers that you have identified to doing briefings. No, I want you to hear the whole lot. I want you to have the whole lot. All the barriers that you have with briefings.
Long lists, short days, late arrivals, MDM meetings before lists.
We'll just back up a second. When you say late, just long days, what are you really planning there?
Talking about at the start of the day, knowing it's going to be long and wanting to get started.
Okay, so time, like the delays.
Yeah.
Okay.
People who don't buy in, sort of lack of commitment to the briefing. Egos, that power issue, I suppose. Focused on their specific task. That could be across disciplines, just they're so focused on the task they need to do. Extra time added to the operation, or the perceived extra time that debriefings are going to add, and team culture.
Team culture, you mean
General culture.
about
collaborative. Yeah.
All right. Now, just what other any other additions that this group might have to the barriers?
I'll run through what we've written down. Surgeons not present and anaesthetists not present, and part of that is around ward rounds, particularly for the ortho team. Everyone together there at the same time, so that they're not taking off doing their jobs. Time limitations, setting up and everybody doing their jobs, I guess, or having enough time to do their jobs as well as doing the briefing. Communication, equality, yeah.
Any other comments that this group made in terms of any other barriers and just keep hold of that? Any other barriers? If they're all there.
We've got some other
We've got some
barriers.
additional ones. We'll pass across.
Yep, so we had change fatigues, so introducing something again, oh no, this is a new change, potentially a new piece of paper, whatever. And utility, being able to see the usefulness of doing a debrief, how is it going to benefit us as a team, getting that buy-in from staff.
So while you've got the microphone,
And we also had acute cases, different surgeons for a series of acute cases.
that's a good point. I think, just to put it in context, the briefing that we are promoting is predominantly for a theatre list. The value for an individual case is relatively minimal, except in certain circumstances. The certain circumstances might be a complex case where multiple teams are going to operate on the patient, where you may elect to have a briefing before that case, or say a major trauma case where there's a lot of different procedures. You know, the orthopod's going to do the arm and then the leg, and then somebody's going to do something else, and the plastics guys can't come in and do the face. That sort of case may benefit from a briefing, but in general, that's sort of in the when you're getting really good and comfortable and you feel it's appropriate to do. But in general, the sort of target we've got at the moment is the standard operating list with 2, 3, 4, 5 cases on it, that sort of stuff. So good point. So while you've still got the microphone, we'll start there. What are the potential solutions to those barriers, or what strategies could we initiate that might limit the barriers in some way?
We went on and did debriefing barriers. We didn't
Yeah,
do.
no, I don't want to do debriefing. I want to have the solutions
Okay.
to that.
Yeah, just making sure that all people realise that they're expected to be on work on time, so they must be punctual. Why can some people manage their work demands and other people can't? And what else?
I think knowing the benefits before you introduce it, show the literature of what the benefits are to that, so that people understand why we're doing this.
having a little sales package to deliver, to say, right, we're going to do this, and this is going to be the perceived benefits, this is what we could get out of it, talk about potentially saving time.
Well, do you think it takes resource, though? I mean, what resource does it take to do a briefing? Liz, you've been doing briefings. What resource?
Yeah, no, it doesn't actually. Doesn't. All it takes is a commitment and less than 5 minutes.
There are some time logistics, and perhaps I can come to that in a second.
I agree. It doesn't take resources. My senior research project in my training program was initiating briefing and debriefing, and then looking at the safety attitude questionnaire for the theater staff, including registrars, nurses, anaesthetists, consultant. And it took no money. I had no money for this. I just printed off forms, and we introduced this as a package.
Just because I didn't mention it in my talk, and I probably should bring it up, the logistic issue at each different level. I mean, the classic surgeon thing is that I'm doing my ward rounds at that time, and I don't want to come. Well, that's not an extra resource. That's a matter of exactly what is the best time to start, and is there a way around it? And I think there is a strategy around it. It's working around well, that's always the way I've done it, so that's the way I'm going to keep doing it, versus something new, and that's not necessarily an easy thing to do, but there's usually a number of ways of doing that. It may require the orthopaedic surgeon shifting the time of their ward round, or it may require some other shifting. It may require difference in nursing staffing. Of course, there's another challenge, because that's driven by a much more, as I was told when I did this talk in Gisborne, that no, the nurses couldn't be available at 8 o'clock for a briefing because they started at 8 o'clock, and the union said they had 6 minutes to get changed, and they were not able to start and be at a briefing until 6 or 8 minutes after 8. I mean, a minor point, but sometimes just an example that some of the things are not driven by behaviour, but driven by employment contracts. And the third thing is said, well, if it's all too hard and the surgeons need to do their ward round, the nurses can't start till 8 minutes past, why don't we do the briefing at 8:15, and why don't you start your lists 10 minutes later at 20 to 9? Manager wouldn't have that. No, can't possibly have that, because then we'd have to report that all our lists had a late start, and we'd get a big cross from the Ministry of Health. Now, of course, actually they'd save far more than 10 minutes by having an effective briefing in the course of an operating session, but sometimes we are focused on the wood and not on the trees. You know, the Mid-Staffordshire focusing on the numbers and not on the bigger outcome, focusing on the targets that we meant to report in the paper, and not actually the actions that are meant to benefit patients underneath them. So those are all some valuable things, but I'd like to hear from this group about what you think the solutions, seeing you've got Liz on your group here, can help you, what the solutions are to getting briefings going.
Well, our first one was said, which was about timing, commitment to the process, education, and backing that up with data and the benefits of it, providing a big workshop with the multi-disc team to present the briefing and debriefing processes, incorporating from the CEO down, agreed data to collect, consequences, obviously focus more on the positives than the negatives for the consequences, feeding back the positives via storyboards, any updating back to the staff so they can see the quick ones, and the timing for debriefing at the end, also not waiting until the surgeon's unscrubbed, do the debriefing early.
Debriefing next, but I think you've raised some valuable points about solutions, and the good news is that at least our local experience in Auckland to date, and I think Clifford's experience as well, is that there's very little recidivism in this process. It may take a lot to get certain people to start doing a briefing, but once they've done a briefing and had the benefits are things run better for you as a surgeon, as well as an anaesthetist, as well as an operating room nurse. The operations, there's less delays, you finish earlier, you get more cases done. Everyone, there are once they start doing, once they make the change, all right, well, I'll do my ward round between 8:05 and, whatever, or I'll come in half an hour earlier and I'll do my ward round, and then I'll go and, I don't know, go and get a coffee or do some paperwork or whatever between 8:05 and whenever I start. Once they've made those changes and done the briefing, very seldom do you see people 6 months later saying, oh yeah, I did briefings for a while but I stopped because it was a waste of time. It's not a waste of time, it's always a benefit, and people appreciate that. It's just getting them over the hump to start doing it, not once. I don't think you could get them to do it once and expect them to be completely convinced, but get them doing it for a month or 2 months, 6 or 8 or 10 lists, and then look back and say, gee, there are so many circumstances that I can think of where the briefing made a difference to how the list went, and potential problems were identified and sorted out before they even became a problem, that I couldn't imagine going back and then just taking it by chance. Wander up and say, well, I wonder how it'll go today. I'm up for a challenge. You guys know nothing about what I'm going to do except a few names on the board and a few alleged operations. Let's see how it goes. I likened it, there's coming and trying to be involved in an operating room list without a briefing is a bit like, I think, a player on the bench at the Super 15 not actually watching the game, but being hidden away somewhere in the stands and then brought out, walking on the field and having absolutely no idea whether his team's winning, losing, whether they've got 14 or 15 men on the field, or what on earth is going on, and expecting that person then to play appropriately in the environment. The same situation happens in our operating room team. I just raise that because one of the issues, one of the barriers that I think we've got to solve at some point is people all being present, and okay, we're talking about having the surgeon there and the nurse there and whatever, but there are some structural things like nurses that are on different shifts and start later. Should we not brief those people in? Should they not allowed just to wander in, but somebody, the senior nurse maybe, should take the person aside and say, okay, you're coming into the operating room, look, let me just tell you where we're up to. These are the factors that came out of the briefing that you should be aware of before you step into the room. Just a thought. Okay, so that's briefings. Easy. Briefings, easy, simple. What about debriefings? Do you want to tell us about the barriers to debriefings? Yeah. Oh, come on. You've got a volunteer over here. Here we go.
Our biggest one was a logistics of having everybody in the room. Because once the anaesthetist is gone, they're gone. And my own experience was that it was very disjointed and it just kind of fell away. Some of the other things we had was fatigue, and overtime. That has a huge effect. And also, I've gone home at 4 o'clock and the list finishes at 5:30, and I'm not there for the debrief. So how that affects it. Communication and being positive, obviously, with the feedback of what sort of could be done better and things like that. Do you want a solution? One solution was to follow the sign out, following the sign out, do the debriefing right then and there while your patient's still on the table, your anaesthetist is still in the room and the surgeon's still there.
Any additions to the sign out, to the debriefing, sorry?
Yep, we had valuing the information gathered, so the idea that staff will be able to see what debriefing actually got for them, so feeding back to them. And also with the staff changeovers, as with the nursing, sometimes the consultant leaves the registrar to close.
That's the mitigating factor, is identifying that point in time, when the last point in time when everyone is there, and pouncing on that and using it appropriately. And the structural things which you've identified as well, involved in making sure that anything that comes out of the debriefing is actually prioritised up the list, so that it is one of the top priority things for theatre management to deal with, so that it then empowers the debriefing. I've complained about image intensifiers for ages, but when I brought it up at the debriefing and it went on the debriefing list, suddenly it got solved. That sort of reinforcement of having things done. Okay.
And also feeling valued as a team, like that was a great day, you know, and you go home and you feel good about yourself. So, you know, that's a really positive thing from debriefing.
And it starts because you probably had a great briefing, and so everyone knew it was going to be a great day, and everyone started and performed well because they had a very clear idea of what they were going to do. So, any comments from this table on debriefings? No, all right. I've worked you to death. I know that. Okay, so thank you for your input. I would like to collect up your A2 pieces of paper so I can have that information and sort of look at it and see if I can add it into my thoughts as I do these presentations. But I think you have helped identify the issues with briefings and debriefings, and many of you will have mentally solved them in your own minds and would be thinking of them in terms of your own workplace, because we're all different. Equifinality, there will be different solutions for every different place along, with the same aims in mind.